Good evening, everyone. This is Linda House from the Cancer Support Community. We are going to start in just about 2 minutes. Good evening, everyone. This is Linda House from the Cancer Support Community. I wanted to just take a moment and thank you all for joining us this evening for this really important topic. We're thrilled that you could be here with us. I wanted to first just go into a couple of pieces of logistical information. Number one, your phone lines are on mute, so only the speakers will have an open telephone line. But I do want to call your attention to the chat feature on the webinar. So during the webinar, you can chat with the group, you can chat with each other, and most importantly, you could submit questions. What we're going to ask that you do is submit questions throughout the webinar while they're fresh in your mind, and we will be on the webinar as long as we need to be until we get all of your questions answered. So we encourage you to please submit early and often. And we look forward to an interactive webinar with you this evening. So I wanted to just first start by introducing our co-presenters for our webinar, the ins and outs of oral chemotherapy, what you need to know to ensure access. We are a part of a larger coalition or cooperation called SPEAK, the State Patient Equal Access Program, and there are a number of us who work on that coalition. I would encourage you to take a look at the website and become an interested party in that project if you're interested in this particular topic. But we came together and felt that it was extremely important that we start to raise the awareness and continue the dialogue about oral access and oral parity to chemotherapy. So effective January 1st in 2015, there will be a number of new state laws that will go into effect that will help with the patient's burden of cost for those who are receiving oral therapy. And I'm not going to go into specifics now. I'm going to ask my co-presenters to do that as a part of their talk, but they will walk us through step by step what this particular issue is, the work that's been done, and in particular ways in which you, the listener, and your constituents can become involved in this particular topic. So let me start in order of those presenting by introducing to you Zina Cary. Zina is a national patient advocate and government affairs consultant. Zina has more than 2 decades of experience impacting public policy and leading issues campaigns, both at the state and federal level. Her primary focus is on increasing access to critical health-related services, including cancer clinical trials, innovative therapies, health insurance for working and pregnant mothers, Medicaid, Medicare, Part D, tobacco control, a whole host of issues that are really important for patient access. We appreciate the work that you do there, Zina. Zina has also held leadership positions with the International Myeloma Foundation, the Leukemia and Lymphoma Society, the National Health Council's Family USA, and has served as a legislative analyst for Richard Gottlieb, the chair of the New York State Assembly. So that is Zina. I'd also like to introduce you to Marialanna Lee, who is the Government Affairs Director for the Northeast and the Mid-Atlantic regions of the Leukemia and Lymphoma Society. In her role, she oversees LLS's regional policy efforts, working to engage state and federal lawmakers and regulators in improving access to care for people living with blood cancers. Immediately prior to joining LLS, Marialanna managed grassroots advocacy at Susan G. Komen, one of the world's largest breast cancer philanthropies, and I think we're all familiar with Susan G. Komen and the great work that they do. She first started working in patient advocacy in M&R Strategic Services, a Washington-based D.C. public affairs firm specializing in helping nonprofits achieve policy change through media outreach, e-advocacy, government affairs, and grassroots organizing. Marialanna holds an undergraduate degree from Agnes Scott College in Atlanta, Georgia, and earned her master's degree from the London School of Economics. Our fourth presenter, technically, is Matt Shearer. Matt is representing two of the partners in this conversation. He's representing Tallahassee Memorial Healthcare and also the Association of Community Cancer Centers. But Matt is the Oncology Service Line Administrator with Tallahassee Memorial Healthcare in Tallahassee, Florida. He's responsible for all the outpatient oncology services, including radiation therapy, medical oncology, gynecologic oncology, hematology, breast care, the breast care center, palliative care, and infusion services. The Tallahassee Memorial Cancer Center is accredited by the Commission on Cancer. The Sharon Ewing Walker Breast Center has been designated as an ACR Breast Care Center of Excellence and is accredited by NAPBC. In his previous role, he was the Administrative Director of the John B. Amos Cancer Center with the Columbus Regional Healthcare System in Columbus, Georgia. And Matt has over 20 years of management experience. He received his Bachelor of Science degree from the University of Alabama in Business Administration and has an MBA from the University of Mississippi and an MSHA from the University of Alabama in Birmingham. And for those of you who belong to the ACCC listserv, he is a wealth of information and is very free to share his knowledge with others. So we appreciate that about you, Matt. And then last but not least, we have Taylor Patten, and we're thrilled to have Taylor join us today from the International Myeloma Foundation's advocacy team. Taylor's expertise is working to expand IMF's U.S. advocacy program and grassroots network, focusing specifically on prevention, equality of access, continuing innovation, and expanded access to unapproved therapies and treatments for people living with multiple myeloma. Taylor earned his bachelor's degree in psychology and history in 2010 from the University of Alabama. There's a lot of Alabama folks on this presentation staff tonight. And a master's of social work in 2013 from the University of Alabama. While at the University of Alabama, Taylor was chosen to participate in the prestigious Washington Interns Program, which launched his career in advocacy. Taylor lives and works in Washington, D.C. And for you Alabama fan, I'll let you know that we have our Christmas tree decorated with an Alabama baseball cap at the top, at least until the season is over. Yeah. So again, thank you everyone for joining us. And without further ado, I am going to turn the floor over to Zina Cary. Zina.
Thank you, Linda. And thank you, Linda, and the Cancer Support Community for hosting this important event this evening. And I'd like to thank all of you who've taken the time out of your busy schedules tonight to come on for this event. Thank you so much for that. As Linda stated in her opening, our goal this evening is to share details with you about new state laws that go into effect on January 1, 2015. We can also touch on laws that have been in place since 2009 but there was such a wave of new laws that passed this past legislative session in the states that we thought it was important to hold the webinar and let folks know about that. What these laws are designed to do is to limit what patients pay each month for oral cancer drugs. So let's start with the problem. The problem really is about access or lack thereof of affordability to oral cancer therapies for thousands or untold numbers of patients. Typically what happens with oral therapies, patients pay a much higher out-of-pocket cost than those receiving IV therapies. And as a result, patients who take oral therapies often have to pay thousands of dollars each month to fill just one prescription of their oral anti-cancer medications. The issue really is a structural problem with how insurers set up their health plans. We all have health insurance on the presentation here tonight, and so we know that when you look at your benefit, it's laid out in two parts. You have the one side of it is your medical benefit, and then your other side of it is your prescription drug benefit. And the way chemotherapy is typically treated with anyone's health plan is if you need an IV therapy, the benefit is housed on the medical side, whereas if you need an oral cancer therapy, it's housed on the prescription drug benefit side because typically the medication comes in pill form. What patients have to pay for each of those benefits are very different. If you are on IV, you pay you have a monthly copay, which is, on average between $20 and $50 a month. Whereas with oral therapies, because it's housed on your prescription drug benefit side, patients are exposed to what's known as a coinsurance, which is typically, it's a percentage of the total cost of the drug each month that a patient has to pay. A good example of this is a patient that I worked with when we were working to pass the law in New York back in 2011. She was a graduate student at Columbia University, and she had chronic myelogenous leukemia, and the drug that she took was Sprycel. And without insurance, the total cost of that drug was $11,000 a month. With her 20% coinsurance, she had to pay $2,200 a month just for one to fill one prescription of her Sprycel. Because of her disease, she took that pill 4 times a day, every day for the rest of her life. She didn't have the money, and luckily for her, she was able to get patient assistance through the company that produced that made the pill. But after we were able to get the law passed, her out-of-pockets went way down, and she was able to afford it on her own. Oral cancer drugs are the wave of the future. They're saving lives. More than 30% of new therapies in the research pipeline are oral. So ensuring that patients have access to treatments, not just now and today, but down the road, is really essential. So what's the solution? As I stated before, it's critical to limit what patients pay for oral cancer drugs each month. So how do we do this? How do we accomplish this goal? The first state to tackle this issue was Oregon back in 2008, and they took the approach that's up until I would say the last 2 years has really been the approach taken by most states. It's what we call nicknamed oral chemotherapy parity. But essentially what we say in these bills is that if a patient needs an oral therapy, chemotherapy is chemotherapy regardless of how it's administered. And so if a doctor says to a patient that the best treatment for them comes in pill form, that patient should not have to pay more than what someone who is taking an IV therapy has to pay each month. So we're not saying move the benefit from the prescription drug side over to the medical side. We're saying just the patient taking oral should pay what the patient taking IV is taking. So their cost every month would go down to between $20 or $50, which really just depends on what that person's benefit requires in terms of a copay. So taking a look at, opposition, as you all know, I think many on this event have been in the trenches with us on this issue in a range of states. So, as you know, opposition to this is fierce, and the opposition tends to come from insurers and the business community. We have standard arguments that we've heard over the years that we've managed to successfully fight off in order to pass bills, and I thought I would just take a minute and list those out so that folks know what hurdles we've had to clear to get to where we are today. The first argument that we typically hear is that these bills are mandates. And, what we push back and say is that these bills are not mandates, these laws are not mandates, because we aren't asking insurers to cover a new benefit. All we're saying is that if a health plan includes coverage of chemotherapy, that the out-of-pocket be equal, that the out-of-pocket for oral cancer drugs be equal to what the patient taking IV pays. We also were given kind of reinforcement on this back in 2012 when the Centers for Medicare and Medicaid Services, CMS, issued a guidance in the context of the Affordable Care Act. Basically, it said essentially that oral chemotherapy parity laws, bills and laws in the states are not deemed as mandates on the states. So, between the fact that we're not asking for a new benefit and the fact that CMS has clarified that this isn't a mandate, I think that settles that matter. The second big argument that we've heard over the years, and I know going into the news cycle we will hear again, is that legislation will increase premiums for all. Fiscal impact studies were conducted in 15 states with laws limiting monthly payments, and a good portion of those states zero increase was projected. And in states where there was an increase shown, it was the highest we saw was 90 cents per month per member. So it's really on the nominal end of the scale that there were premiums increased. Legislation is about choice and convenience. These drugs are prescribed because they're the best therapy, that the oncologist has deemed these to be the best therapy for those patients. And for some cancers like chronic myelogenous leukemia and multiple myeloma, oral therapies are a centerpiece for their course of treatment. It's also important to ensure that affordable access to IV and orals is made because of combination therapy. And a great example of this is multiple myeloma, where there's 4 main treatments. 2 of them are oral and 2 of them are IV. And so ensuring that multiple myeloma patients and other cancers that use combination therapy, making sure that both IV and oral therapies are affordable is critical to saving the patient's life. Number 4, legislation opens Pandora's box for other chronic and life-threatening diseases. There are a lot of other conditions where drugs are expensive, but we have not seen, where we've introduced oral chemotherapy parity bills, we've not seen, and gotten in the past, we've not seen other chronic conditions coming in behind us and clamoring for their disease to be included in this. It's really a cancer issue at this point. And then probably the top 5th argument we heard in the last cycle was that the Affordable Care Act would fix this problem. The Affordable Care Act has reduced out-of-pocket costs for untold numbers of uninsured folks, but unfortunately it does not directly address the issue of what a patient who needs an oral therapy takes each month. It does put an annual cap on out-of-pocket for patients, but again, it does not individually get down to dealing with what someone like a CML patient needs to pay, what they would pay for their monthly out-of-pocket for their Gleevec or their Sprycel. So what's the good news? The good news is that starting January 1, 7 new states will have laws that limit what patients pay each month for their monthly out-of-pocket. Arizona, Kentucky, Maine, Missouri, Georgia, Ohio, and Wisconsin. I won't get into the specifics of each of these states because Marialanna Lee from LLS will touch on that in her slides. But it's great news, and for those patients living in those states, the out-of-pocket will go down significantly. And with those 7 states, that brings us to 34 states and the District of Columbia that now have limits on what patients pay each month for their cancer drugs. Who does this help? These laws help many patients in the states who have private commercial insurance, but it does not apply to Medicare or certain private plans. If you would like to find out more information, we'll have resources available. We'll give you information on other resources later in the presentation to find out whether or not these laws in your states would apply to you. So just one final slide for myself, taking a look at the big picture around the country. As I mentioned, 34 states and D.C. have passed laws that limit what patients pay each month for their oral anti-cancer medications, which is excellent news. And if you take a look at the map in this next slide, which was provided by the International Myeloma Foundation and the State Patients Equal Access Coalition, SPEAK, you can see the states that are in blue, those are the states that have signed legislation into law. And then the states in the green are states that will have active campaigns starting January 2015. Unfortunately, the states that are in the white, there's no activity right now in those states. If you are from one of those states and have an interest, we'll give you information later in the presentation on how to get involved. But I'll leave you with this. We have 34 states in D.C., and we have 16 states to conquer. And so, the tagline here is, let's get 16 and 16. And we hope that each of you on the phone will work with us on that to make that possible. So with that, I would like to turn it back over to our gracious host, Linda House with Cancer Support Community.
Well, thank you, Zina. That was great information and very helpful. I'd also just quickly like to remind those who are with us on the webinar that the slides will be posted to the website. So you'll have access to these slides well after we conclude yet this evening. And we do have a question. We are going to hold it till the end of the evening, but thank you for submitting your question, and I would encourage others to continue to send theirs in as well. So I just wanted to take a couple of minutes here this evening to put a lens of the patient perspective on this particular conversation. And as a point of background, the Cancer Support Community is the largest nonprofit provider of psychosocial support for people living with cancer. And that would be the patient as well as the family unit or caregiver unit, depending on the particular patient. So we have 170 locations throughout the United States, 4 international locations, and we also provide support through a telephone helpline. And I go through that just to say, if you have patients that are having challenges with their oral medications or any of their medications, we stand ready to help support them, along with a number of our patient organization partners, which you will hear more about throughout the course of this evening and then also at the end. I also raised that to just share with you the fact that we are seeing a number of patients who do have challenges gaining access to treatments. And in particular, it's one of the driving forces of us being a part of this particular project. And, in particular, the cost of cancer care. And when I use the term cost of cancer care, I really use that sort of comprehensively. So it's not just the cost of the drug. It might be time off work. It might be some of the other factors that come into play for people with cancer. And, we feel like not only should patients have access to drugs, they should be able to afford their drugs or treatments, and they should also be able to receive those treatments in a way that is convenient to them and doesn't put an additional stress on that particular family unit. And just a bit of the research that we have, we also have a research and training institute in Philadelphia where we are generating information about the cancer patient experience. And we've had a couple of opportunities to release data from that particular registry over the course of the last couple of weeks, the last 6 weeks or so. And this whole issue of financial burden and compliance, particularly in oral therapies, we know from the registry report that as many as 15% of patients, this is the overall registry, patients with any type of cancer, but 15% of patients postpone filling prescription refills and or skip doses and split pills because of not having affordability to their prescribed medications. What's even more striking to me is data that we released on Sunday at the American Society of Hematology, where we looked at patients, in particular with CML, who, as you know, is a highly curable disease given some of the recent progress that we've made in treatments. And for those patients, if they have a financial burden, 32% of the patients were likely to be non-adherent with their medication. 32% of a patient population that have a potentially curable disease. Now, if you couple depression with that financial burden, the number of non-compliant patients increases to 57%. So over half of the patients with a curable disease are non-compliant with medication when you couple both financial burden and a risk for depression. So as you can see, this is a pretty significant issue for us as a community, which I include everyone listening on the phone and on the webinar now in that larger community. And it's really something that's not acceptable in today's environment in 2014. So that's essentially why the Cancer Support Community has become involved in this issue, why we will stay involved in this issue as we continue to advocate for access and affordability for all patients. So I would like to just publicly thank those who are working on this particular issue through Speak, Zina, our partners in the pharmaceutical industry, our partners on the Hill, to really help right-side this equation for people who have a chance to have a long-term survival. And with that, I am going to turn over the microphone to Marialanna Lee from LLS, who will share with us her insights about the work that she's been doing, which is long-standing. Marialanna?
Thanks, Linda. Good evening, everyone. Thanks for joining us, and thanks to Linda and Zina for having me on tonight's webinar. Again, my name is Marialanna Lee. I serve on the Government Affairs team at the Leukemia and Lymphoma Society, or LLS. Our mission, as many of you may know, is to cure leukemia, lymphoma, Hodgkin's disease, and myeloma, and improve the quality of life of our patients and their families. LLS provides free information and support services, again, for our cherished patients and their caregivers and their families. And we're also very proud to be able to fund life-saving blood cancer research all around the world, including, in fact, research that has resulted in new orally administered therapies becoming available. So that's LLS in a nutshell. Now, policy-wise, our focus at LLS is on policy issues that accelerate the development and approval of innovative treatments, but our focus is also on policies that will ensure patients have sustainable, affordable access to those treatments, right? What's the value of innovation if patients can't actually access it? Now, in the case of oral therapies, as Linda was just saying, there are many hugely significant blood cancer treatments that are administered orally. So when you take all of those factors and put them together, this particular issue has, for many good reasons, been among our top policy priorities, for several years now. Now, as Zina mentioned a couple of seconds ago, we have many new laws that are going to be taking effect. Most of the states that you see referenced here will be taking effect in 2015. Arizona, I know, is 2016, but Arizona and Maine, both of those states have enacted laws which obligate insurers to apply the same cost-sharing rules to all cancer medications, regardless of their administration format. And then if you look at Kentucky, Missouri, Ohio, Wisconsin, these are states that took that alternate route of capping the out-of-pocket costs that patients can be obligated to pay for their orally administered cancer therapies. I think, policy details aside, it is really truly worth a moment of celebration, knowing that people in these states, people living with a blood cancer or another form of cancer, are going to benefit from this new protection, and in a really very profound way, right? So many patients and physicians, so many more of them will be free to make treatment decisions based upon what's most clinically appropriate for the patient, which is just so absolutely critical, rather than having to choose a treatment simply because of what the out-of-pocket cost might be. So again, a tremendous improvement in coverage, and as some of the speakers that have gone before me have already said, I too have to add my thanks to all of the patients and families who shared their stories in order to bring these bills to life and convert them into actual laws in these states and the others where this protection has been in place for some time. Now, something I want to talk about for just a second is what to do if you live in a state that has a parity law and you suspect that your plan is not adhering to that law. Now, my recommendation would be that you first contact your health insurance plan to inquire about how the law in your state impacts your particular plan. And then if after that conversation you feel like the issue hasn't been appropriately resolved, then you may want to contact the Consumer Protection Division within your state insurance department to ask about the rights and protections that are due to you. Now, this may be called something slightly different than a Consumer Protection Division, but if you use those words in a search query along with insurance department and the name of your state, I'm sure you'll be able to find that information right at the top of your search. Alternatively, you may find it helpful to get in touch with the patient advocacy organizations that are participating in tonight's webinar, or some of the many other fine colleagues that we have out partnering with us in the field. When we get closer to the end of the slide deck, you'll see a slide that provides contact information for some of our organizations, and I know Taylor will reference that as well. Again, you're always welcome to reach out to us to discuss if, how, where we may be able to offer guidance. And, again, know that many of us are still fighting for these bills in many other states, and we're also working on other patient protection issues. So we're always looking for new advocates to join our families. So with that, I'm going to turn things over now to my colleague, Matt Shear with Tallahassee Memorial Cancer Center.
Thank you, Marialanna. Give you a little bit of background, Tallahassee Memorial is a nonprofit community hospital, and we have a comprehensive community cancer center here that serves somewhat of a rural population, but the population is about 850,000 people, and we are the state capital for Florida. Oral chemotherapy has probably been around at least 2 decades, but most recently, probably over the past 10 years, is where we've seen a significant increase in the use of those. Currently, about 10% of all treatments are oral chemotherapies. So far in 2014, the FDA has approved 25 specialty drugs, and of those 25, 5 of them, or 20%, were actually new oral chemotherapy drugs. Also, of the 125 drugs currently in phase 3 testing through the FDA, 38 of those, or 30%, are oral chemotherapy agents as well. So there's lots of new drugs in the works, in the pipelines getting approved. And the estimates state that probably within the next 5 to 10 years, 25% of all chemotherapy will actually be of the oral nature. So all the more important issue that we do get this addressed in every state so that our patients can have access to this. Through the Association of Community Cancer Centers, they had put together a task force to put together some best practices related to oral chemotherapies because they knew that they were seeing from the members, and we were hearing from the members and their patients, a lot of these issues with access and cost. Some of those best practices identified were, prescribe only 1 month at a time. Make sure that you give not just patient and family education, but extensive patient and family education about the drugs, what the therapy is, side effects, and the importance of compliance with taking those drugs. A pharmacy consult was also recommended as part of that education, so that potentially they could meet with a pharmacist and get further detailed information. And as we mentioned, another best practice they identified was also to have a financial counseling with those patients because, as stated, depending on where you may be, you may or may not have adequate coverage at this time. So financial counseling for patients was a critical best practice identified by ACCC as well. As we mentioned, they are a high cost if they fall under your pharmacy benefits. As we talked about, patients have to pay anywhere from $500, $1,000. We've even seen a couple of patients who were expected to pay $10,000 a month for their prescriptions, and obviously a majority of us don't have that kind of money laying around to buy one prescription, much less if it was several prescriptions. And most patients, can't afford that, and then how can we work with them and our drug companies to get them access? In particular, in 2011, ASCO did a study, and it showed that if patients were required to pay $500 or more, 25% of those patients didn't even get the prescription filled. So not only not being compliant, a quarter of the patients couldn't even get the prescription filled, so they didn't even have a chance with that aspect. The study also showed if the copay was $100 or less, which could sound like a reasonable amount, even then only 10% of the patients didn't get their prescriptions filled. So one, just gaining patients access to being able to get those prescriptions filled is a vital part of this. And then even once the patients get their prescription filled, with a high-cost prescription like that, there's a high rate of non-compliance. I can remember talking to one particular patient and us trying to determine why they weren't taking their prescription as prescribed is they felt, well, if I'm having to pay $1,000 a month, I'm going to try and make this prescription last 2 months. Well, one, we need to do a better job of educating the patient about that, but that was their idea is, well, I can't afford $1,000 every month, but maybe I can do $500 a month. So when you have that non-compliance, that only compounds, all the issues from, patient side effects and that kind of stuff. One study that I read, it estimated that non-compliance of prescription medication, not just oral chemotherapy, but all prescriptions, cost our healthcare system $290 billion in avoidable cost. So a significant part of that would be tied to oral chemotherapy. Here in Florida, our physicians here at Tallahassee Memorial, along with around the state, joined the fight back in 2012. In particular, we worked with not only ACCC, but the American Cancer Society and LLS very closely as we worked through getting our legislation passed. And it took us a total of 2 years of working with our legislators before we got it successfully passed in 2013. And even then, it didn't become law until the middle of 2014. But, it took an active group of physicians, employees, nurses, patients, and administrators meeting with and testifying in front of our legislators on a consistent and regular basis to be able to get this passed. And, you may think, oh, well, it's one phone call or just one email and it's not going to make an impact. Well, when you add the snowball effect to that, when your one email goes along with, 50, 100, 200 other emails from other individuals, it makes a huge impact with your legislators. In particular, we used every communication method, I think, except for carrier pigeon. We used email, personal visits, phone calls, even tweeting directly to our legislators, those that had the Twitter accounts, and even using Facebook as well in communicating with our legislators and getting our community involved with being advocates for our patients. In Florida, in particular, again, with our legislation and how it was finally approved, is any new plans that are issued after July 1st in 2014, they're covered by this new wording such that the oral chemotherapy is treated the same as IV chemotherapy. And then effective January 1st, 2015, all plans, because most plans renew around January 1st or in January, then all plans become effective at that point. So it was definitely a very large concerted effort along with many of the organizations on this call. So I just want to encourage you, for those people that may be in those remaining 16 states that we want to get on board by 2016 to get involved. If it's a neighboring state, like in our case, we treat a lot of patients from the southern part of Georgia, so we're keeping our eyes and ears open in that state. And same thing with Alabama, is we get patients from Alabama as well. So we're willing to work with folks in those states too. But encourage you to get involved. And it is important that our legislators hear from us on these important issues. With that, I'm going to turn it over now to Taylor Patten. Taylor?
All right. Thank you so much for that wonderful introduction, Matt. And it's really great to hear from another Alabama grad. So really good to hear that. As Linda said earlier, I am an advocacy associate with the advocacy team at the IMF. And we are the oldest and largest organization dedicated to finding a cure for multiple myeloma. And we've been a long-time champion of affordable access to oral cancer medications, oral anti-cancer medications, rather, really since the inception of this issue. We have been working on our Black Swan Research Initiative, and so that's been bringing together leading experts in the field of myeloma research to find a pathway for a cure. And of course, we're also dedicated to amplifying the patient voice to help pass legislation that supports the cancer community. And one of those key issues that we work on is oral parity. And we do that by spearheading 2 coalitions. One is our National Patients Equals Access Coalition, or PEAC, And we also have our State Patients Equal Access Coalition, or SPEAK. And these coalitions coordinate the advocacy community to pass legislation to increase access to oral anti-cancer medications. And so what that means really is that we are not operating in silos. All of these organizations aren't just working by themselves with their own agendas, doing their own different things. We're all coming together as a broader coalition and collection of organizations to help the patient community and really work together to spearhead and focus this issue in all of these states. As Zina mentioned so eloquently earlier, SPEAK has helped pass parity laws in 34 states, plus the District of Columbia, and that's all great and wonderful work. However, moving forward, we do still have 16 remaining states that have yet to pass these laws, and what the good news is that SPEAK is currently working on 8 additional campaigns in other states, and those would be Mississippi, North Carolina, North Dakota, New Hampshire, Pennsylvania, South Dakota, Wyoming, and West Virginia. And so through those campaigns, we hope to bring oral parity to these states in 2015. We also have, and this is primarily what PEAK works on, at the federal level, we have 2 bills that have been introduced that are working for oral parity on a national level. And so we have our House Resolution 1801, which is the Cancer Drug Coverage Parity Act 2013, and that was introduced by Representative Higgins from New York. And we also have Senate Bill 1879, which is the Cancer Treatment Parity Act of 2013, and that is co-sponsored by both Senator Franken from Minnesota and Senator Kirk from Illinois. And so you may be thinking, why have these bills when we've been so successful in the states? And the answer to that is really because currently we have a patchwork collection of state laws with varying levels of access between each state. And the federal bills would provide access to those states without laws, in addition to covering the individuals that the state laws miss. As Zina mentioned earlier, there are some individuals that aren't necessarily covered by these laws, and so the federal law would help work to ensure that access. So it's a great opportunity, really, to get these laws passed, to provide that network for the entire nation. And so, really, you might also be asking, if we do have a federal law, will that preempt all the great work that we've done in the state? And no, it won't. Really what it'll do is it'll just provide a threshold for each state to have to live up to. And so if states do go above and beyond that level of coverage, that's great, but it will provide that minimum level of coverage that all states have to hit. And so finally, what comes next? Why are we here? The bottom line is that there are millions of patients across the country without access to the life-saving medications that they need for their treatment. And oral parity is just a great way to provide those individuals access to these medications regardless of the method in which it is provided. And so how can you help with this? We do have, as Matt so eloquently said in his presentation, if you really would like to join on and be an advocate, there are several ways to do that. Use social media, use Twitter, Facebook, reach out to your representatives, send them letters, create meetings in districts, particularly going into the holidays. A lot of representatives are going to be going home, and you may be able to have the opportunity to speak with them while they're in district. So there's lots of opportunity to do that as well. Also, I wanted to go ahead and talk about some additional resources on our next slide. And so, as you can see, if you are interested in learning more about these organizations, you can see all of them listed here. We have the Cancer Support Community with their Cancer Support Helpline, as well as the Leukemia and Lymphoma Society with their Information Resource Center, as well as the Association of Community Cancer Centers, their website, as well as my organization's website and our info line. Additionally, for those individuals that may not be covered by certain plans within their states, or if you would just like some additional resources for covering medications, there are also 2 additional organizations, the National Patient Advocate Foundation, as well as the Patient Access Network. All of these both of these programs do provide co-payment assistance programs as well as general resources on how to access all of your medications that you may need. And so finishing that up, I would like to pass it back over to our wonderful host, Linda House.
Thank you, and thank you so much for that great information. I really appreciate all of it. I will just let you know that we will update these slides with the additional information that Taylor just mentioned. So the updated slides will have websites and telephone numbers for you. So stay tuned for that. It'll be right up right after the webinar. So we do have some questions that have come in. One in particular is more of a logistical question, and it is about a transcript. So we will not have a transcript, but you will be able to go back into this very link and listen to the webinar again. So the slides will be available for you, as will a recording be available for you to take a listen to. So I'm just going to throw this question, I think, to you, Zina, and Margaret. I'm going to withhold last names, but Margaret's on the line, and she says she appreciates the work at the state level. However, there is a bill in committee in Congress which would obviate the need for individual state laws. So could you speak to that a little bit, Zina?
I can try. I never like to. I don't want to. I'm not actually familiar with that bill. I'll be honest. But if there are other presenters on here who have some familiarity with that bill, that would be great. But my guess is that given that it's lame duck, and the fact that it is a fairly outrageous piece of legislation from the sounds of it without reading it, I can't imagine that something like that would pass Congress. But again, I'm not familiar with the legislation, and it may be one of those things that we could look into and get back to you on. Sure. And again, I asked my colleagues on the panel if anyone else has familiarity with that. That would be wonderful.
Okay. Great. So we'll get an answer, and then we'll be able to send it out to those who have registered on the webinar. A quick question from Tim: do the laws apply to the state where the patient lives, or where the dispensing pharmacy is located? Matt, I'm going to see if you can tackle that one for us.
Be glad to. It should apply where the patient lives. Because that's going to be where their insurance coverage is. So, for instance, if they live in Florida, in my case, but their insurance requires them to send it to a specialty pharmacy, let's say in Georgia, the insurance coverage is going to be for the state of Florida. So even though that, quote, dispensing pharmacy is in Georgia, isn't going to matter. It's their insurance company has contracted with, that specialty pharmacy wherever they may be. If it's in their state or outside of their state, their insurance coverage works in that state. So it should apply where that patient lives and not where the specialty pharmacy is located.
Great, thank you. And then we have a question from Norman, who is asking about sub-Q therapy. So when you look at sub-Q injections, does it matter whether the shots are administered at the clinic or the home? Matt, I feel like that's something you could take as well.
Sure. So, yes, it would matter, again, just as a general rule of thumb, based on that, yes, it would matter where the drug is dispensed and then given. So depending on the patient's coverage with an injectable medicine, typically, from my experience, what I've seen is if it's prescribed, dispensed, and then given at the clinic, whether it's a hospital clinic or a private practice, is usually a little bit cheaper. And in that aspect, it's a little bit more safer because we know how the medication has been handled, stored, and all that good stuff. Versus at home, the insurance company's not going to be paying, a dispensing fee or a fee for the delivery of that medicine. But a big issue the home delivery too is, did the medicine sit on the porch, all day in the sun until somebody got home to take it inside? Was it stored properly and all that good stuff? But that's a good point. Is that could be the next round, if you will, as we continue to look at patient access to the appropriate drugs to treat cancer, is how it falls in with where it's administered and where it's dispensed.
Great. We have a question from Elizabeth about how to find out the laws that are in California. And Taylor, maybe that's something that you could speak with. Sorry.
I actually will defer that to Zina. I don't have the specifics on everything that's going on in California, but I know that Zina has more of a grasp on that.
Great. Sure, I'm happy to take that. California did pass a law, not this past session, but the session before, and what it does, it takes a little bit of a different approach than your typical parity law, quote unquote. And what they've done is they've put a cap on what patients pay each month. And the monthly cap is $200 per prescription per patient. There's a provision in the bill or the law that allows the state to take a look back and assess whether or not it gives them the flexibility, ensures the flexibility to do a nominal increase each year of the cap. But it's a very, very limited amount that would go up. But it's $200 per prescription per month, and I believe it's effective. It was effective last year, so it's in place right now. It's not ideal, but it certainly will help. It certainly will help some patients.
Great. And I think this is one that either Taylor or Marialanna, you could answer. But I have someone who's specifically asking about the state of Pennsylvania, but I suspect there are other folks on the line who would want to know how they would be able to find out who to contact in their particular state. So does SPEAK have a resource that's available, and could they email someone at SPEAK, or would you suggest that they contact someone else?
So SPEAK does have the access map that Zina mentioned earlier. That is on the SPEAK website, which is SPEAK, speac.myeloma.org. And if you click on each individual state, it will provide you information on the specifics, and it will also give you information on who to contact as well.
Great. And it looks as if that website is noted on slide 9, just as a reference.
Yes, it is.
Okay, great.
And if I could very, very quickly, this is Zina. Taylor, if you could just for a minute speak to the wonderful materials that are available, the library of resources that SPEAK has put together, that would be great.
Sure. So the SPEAK Coalition has several documents that are available if you are interested in, contacting your legislator. There's talking points that give you different statistics and different things that you could talk about your legislators with. Of course, we do have the access map that shows what's going on in each individual state and gives you all of that information. It also has a one-pager that you can send out to any of your legislators or anybody that may be interested in oral parity that has, once again, different facts and numbers that you may be able to convince them to join the effort with, and just a broader collection of resources that you can use in this effort to ensure oral parity. So if you do have any questions about that, feel free to reach out to me or anyone that's on this call, or join or look at the SPEAK website, and you can see those documents listed there as well.
Great. And just an announcement from Russell, who posted that he was able to get the oral parity bill introduced in Tennessee today, and that Senator Randy McNeil will sponsor it. So congratulations. Nice job.
Linda, this is Zina again, and to the audience, I apologize. I just wanted to clarify the effective date on the California law is January 1, 2015.
Great. Thank you. I have another question from Elizabeth in California. What do I do if I have patients who are being asked to pay more in California? So Elizabeth, maybe you could type a clarifier. Are you asking more than an IV or more than the reference? If you could clarify that, we'll come back to that particular question. Tim is asking, please clarify if these state laws apply to Medicare Part D plans.
I can take that and the last question, if you'd like, Linda. They do not apply.
Go ahead and take that one
which
first.
One?
We'll come back to Elizabeth.
Okay, sure. Which one? The California?
Part D. No,
Part D. It does not. Unfortunately, state law cannot impact the Medicare program or certain private plans that are exempted by a federal regulation. I don't want to get too far into the weeds on the policy of that, but for certain, it's just important to understand that in these state bills, we cannot touch Medicare, and we cannot touch the federal Medicare program.
Okay, great. And Elizabeth says her question was answered.
Okay, great.
And I think that we have exhausted questions. I'm going to pause for just a couple of minutes before I close this to see if anybody else has a question that they would like to submit. Sure. Okay, I would like to offer thanks on behalf of my co-presenters here. So thank you, Zina, Marialanna Lee, Matt Shearer, Taylor Patten, and ACCC for co-sponsoring this webinar with us. And I'd also like to thank our sponsors. You know, so often we don't recognize the great work and the partnership of our sponsors. So thank you to Celgene, who was quick to step up and help us deliver this webinar. And then also thank you to Millenium, the Takeda Oncology Company. Without your support, this webinar would not be possible. So in closing, please know that the slides will be online and available to you. You have contact information for our organizations. Any number of us who have been on the webinar this evening would be more than happy to answer any questions for you or to get resources. I've made a note of the couple that we do owe you, and we will certainly get those to you. And we hope that you have a great holiday season. Thank you so much for joining us this evening.